what was clear 10 years ago was that we could not speak about diffuse large B-cell lymphoma as one single lymphoma. So first, with gene profiling, they made a distinction clearly between what we call the GCB and the non-GCB diffuse large B-cell lymphoma. And around this definition now, we know the different pathway affecting that. So that's not just something that which was a dream, you know, that's something real. And moving more and more to the description of the different pathway, now with the next generation sequencing, much cheaper, we can see what we saw with gene profiling. We can see more of the different type of mutation, and we can use it in paraffin block. And that's the biggest difference. So we can go back to our file, our data, look at the material and make new work on that. All these new drugs are working, you know, at the present time, and you have a lot of new drugs. And so that is becoming more a chronic disease, not like myeloma, but with the strategy that we are using, chemotherapy, stem cell transplantation, we can extend the progression-free survival to a median of 8 years when it was 10 years ago, around 3 years. So that's the biggest decision and the biggest input of chemotherapy. Now we have some agents. First, Rituximab, of course, was used in combination with chemotherapy and did improve the result, and as maintenance treatment. And the French group reported here the result of a study, new patient transplanted in first remission, and randomization of Rituximab for 3 years every 2 months. And there is a 15% improvement in progression-free survival. So that's quite impressive, and that will be one of the standards. The other thing during this study, and with the European mantle cell network, joining together basically the German and the French group, Christian Pot was able to monitor the minimal residual disease during that type of study. So now we know that we can achieve a complete remission, not only looking at the node, but looking at the bone marrow or the blood. And when you look at this minimal residual disease, you can follow it. And if it disappears, it's good. If you have a regrowth of this minimal residual disease, at that time, it precedes the clinical relapse. So that may be in the future a way of introducing drug at a time where the bulk of the disease is not so big. Now that's just the beginning of the discussion, and we will have to wait for that. But there is another drug, very active, Ibrutinib, which was registered in mantle cell lymphoma in relapse. So we will include it in first-line treatment with combination chemotherapy and randomize as maintenance the standard, future standard of treatment. So I guess now we have several very important tools, and I guess the question will be like in myeloma, do we need still autologous stem cell transplantation or not? We will see.